All right. Hello, everyone. We're going to go ahead and get started. I know it's a small crowd, but we are having a couple of people having some technical issues. So I'm working them through that. So hopefully they'll be able to hop on here shortly. But it's 3 after. We want to be mindful and get everybody out here on time. So we welcome you to the first session of the MS and Neurodegenerative Diseases ECHO. We appreciate you hopping on. Today is going to be an introductory session. We will review kind of the partnership that Project ECHO and the Institute for Public Health Innovation have put together for the ECHO, and go over what's involved in the session, a little bit of the curriculum. We'll show you the case form for the project, answer any questions you have, and then kind of get you ready for the next session in February. We'll kind of kick off the curriculum with getting into the meat of the topics. So to start off, why don't we go ahead and do some brief introductions since we do have a small group. So I'll start. My name is Jay Mason. I'm the director of the ECHO program here at the West Virginia Clinical and Translational Science Institute. And I will be your host for most sessions. So if you have any issues or anything like that, please email or chat me at any point. But I'll just call out the Hollywood squares and tell us who you are and where you're from. So Lauren, why don't you go ahead and go first?
Hi, everyone. Good afternoon. My name is Lauren Ruiz. I'm a senior program manager with the Institute for Public Health Innovation. I'm based in Richmond, Virginia, but the project that I lead for rural multiple sclerosis solutions spans Virginia, Maryland, North Carolina, and West Virginia. I've been with the organization for about a year, but I've been working with populations impacted by complex chronic diseases for about 15 years, or really my entire career since graduating. So this is my space that I like to be, and I am really thankful that all of you are here to help learn more and support these communities in the important work that you do. Thank you so much.
Thanks, Lauren. Sarah?
Hi, good afternoon. I'm Sarah Ward. I'm the Community Engagement Manager with the Institute for Public Health Innovation, working on the same project and geographical area as Lauren has described, and really excited for this partnership and this event, and grateful to have you all on board. And
Thanks, Sarah. Let's go to Melanie.
Hi, I'm Melanie Ward. I'm one of the MS specialists here at WVU. I will be presenting some of these sessions. So yeah, I'm pretty excited about MS stuff.
Thanks, Melanie. Yes, Melanie is one of the subject matter experts and will be presenting some didactic information and also help answer any questions or anything the group might have. Let's go to Samantha.
Hi, everyone. My name is Samantha. I am one of the clinical pharmacists at the WV Medicine Specialty Pharmacy. One of the areas that I work in is neurology, which a lot of our neurology patients have MS. So I'm excited to learn more from the experts here.
Thanks for joining, Samantha. Let's go to Eric. We're just doing introductions. If you could tell us who you are and where you're from.
Sure. So I'm Eric Sechrist. I'm also one of the MS specialists here at the clinic. Yeah, that's what I do.
Thanks, Eric. Appreciate you hopping on. Let's go to Tanisha.
Hello, everyone. Here, I'll turn my camera on. I was eating lunch, so.
It's all right.
It's okay. So Tanisha Johnson Davis, I'm an executive director at a small nonprofit called Simple Provisions, right? So I wear multiple hats. One of the things that we focus on is food insecurity, right? With the weekly food distribution that we do. We're also looking to get into providing a little bit more social support, right? How do we get into, if we get into navigation, what are the things that we have to think about, all the populations that we have to think about that we touch, right? So we know that we engage individuals that have diabetes and hypertension, but they may have other things, right, that we don't really talk about as much. So that's why I'm here, to learn more.
Awesome. Thank you so much for joining. And then Michelle.
That's great.
Yeah.
Thanks for being a part of this.
Well, thank you, Innovation for Public Health. That's how I found out about it. So the Institute for the Innovation of Public Health. So thank you for sharing the information.
That's great. No, if anybody else from your group wants to join, please let us know. We'll get them connected into the information. But thank you for joining. And let's go to Michelle. You're able to unmute. If you aren't, please go ahead and use the chat to introduce yourself.
Hi, I am Michelle, if you can hear me. I'm a complex case manager at the health plan. I also am supervisor of Medicaid clinical services here, and I have just joined to get updated information.
Awesome. Thanks, Michelle, for joining. Okay, so like I stated at the beginning of the session, this is going to be the introductory session, and we're going to kind of tell everybody who we are and kind of how this came to be, this partnership, and then also give you a little bit of information about the project moving forward. So we're going to start with a little bit about the Institute for Public Health Innovation. So I'm going to turn it over to Lauren and Sarah. Lauren, you should be able to share your screen and share your slides, give you a brief overview, answer any questions you have, and then we'll get into the meat of kind of what ECHO is and what we're going to be doing. So go ahead, Lauren.
See my screen with a sort of introductory slide for IPHI. Great.
Yes.
Awesome. So I won't need to introduce myself again. We just went through that. Thank you so much, Jay, for taking us through that. I'd love to know who's in the room and who we have with us. Samantha, Eric, Michelle, thank you so much for joining. Tanisha, I'm so excited that we have someone of your background on the call and that will have your perspective as well as we go through these sessions. So I'm just very excited for everyone to be here and to, as Jay said, sort of take you through the concept of how this came to be, what we've heard from our community and how we're really hoping that we can share information with you that you can take back to your communities to really help with some of these issues that we're seeing in our community. So it started in 2009. The Institute for Public Health Innovation, or IPHI, is the official public health institute serving Washington, D.C., Maryland, and Virginia. We are one of more than 40 member institutions of the national network of public health institutes. Basically, what we do is we work with public and private partners to strengthen public health and try to make improvements to systems. The focus of our work is on community health rather than necessarily an individual person's health. We have about 50 full-time staff members. We also deploy staff on a contract basis to respond to surges in public health needs. Examples are situations like COVID or Mpox outbreaks. Those staff numbers can range anywhere from about 150 to almost more than 1,400 deployed staff that we had during the height of the COVID-19 pandemic. So through our program, Collaborative Neurologic Solutions, we are really looking to address the shared needs of people impacted by complex chronic neurologic health conditions. We really believe that collectively, these diseases are a growing public health crisis or a growing public health issue that we really need to address for the health of our communities. We're talking mostly about MS, our multiple sclerosis community, but some of these topics and some of the issues and shared needs that we'll discuss will look at instances of impact on other communities as well, with similar symptoms, similar needs, and similar progression. Some of the other diseases that we look at in our Collaborative Neurologic Solutions program is ALS, or amyotrophic lateral sclerosis, FTD, or frontotemporal dementia, LBD, or Lewy bodies dementia, HD, or Huntington's disease, Parkinson's disease, and stroke. These diseases all are typically diagnosed in that earlier age range, about 20 to 50. So we're not looking at that more aged Alzheimer's population, folks that maybe are already on Medicare, are already financially stable or aging into retirement, children out of the house. These diseases that we are looking at really are affecting those slightly younger demographics, folks that maybe don't have long-term care insurance in place, maybe aren't financially stable, have children in the house, or still caring for their parents. So many different factors that might impact their ability to address or manage a complex disease like multiple sclerosis. Some of these common needs that we see shared across these communities are a general lack of knowledge about the disease. This can lead to instances of diagnosis or more severe disability that maybe were preventable. Many of these populations have to travel long distances for diagnosis or treatment. And with some of the challenges that they face, that can put a lot of barriers in place for them to receive continued or quality care. For these diseases, there's no cure, and many of the treatments can be very expensive or place some type of financial burden on folks that are needing these treatments on an ongoing basis. Some of these diseases still have a stigma attached to them. So especially in smaller communities, folks may not want to disclose their disease or even admit it to themselves. All of them impact all body systems. So this isn't a cold or a respiratory disease that's really focused on one part of the body. These diseases impact every form and function and thing that happens with a person's being. Their cognitive, emotional, behavioral, and social needs are all impacted. I mentioned that it impacts employment and financial stability significantly for families. Many folks need Social Security disability benefits and are unable to continue to work after a certain period of time. Individuals might feel a loss of independence or sense of purpose, leading to isolation, depression, loneliness. All of these diseases tend to have a high caregiver burden. So we're seeing impact, physical, mental, emotional impact, not only for the patient, but for the caregiver, their families, their loved ones as well. And overall, just the complexity of needs and care coordination required to really address this full suite of issues that these populations express to us. Sarah has had some conversations with doctors in the community that are treating MS patients, and some of their feedback to us has been really direct. They said, I've had some patients recently diagnosed with MS, and it is really complicated to address the layers of health and social service needs that these patients encounter. So how can I get more help, better understanding to respond to that? A few further community insights that we've heard from our folks as we have engaged with people living with MS, their caregivers, and their communities. They've really championed the idea of these non-specialty providers having knowledge about their disease and really being on their side, whether that's as an advocate, whether that's as a referral and source of trusted information, or whether that's as an actual treating provider. Those relationships and what they're really asking of those folks in their communities range. based on their capacity and what they might feel comfortable with. But we know one thing for sure is that patients prefer to receive their care near their home in places they trust with those providers, community members, and healthcare professionals that they're seeing on a day-to-day regular basis. And that's, of course, always in coordination with that specialty MS care, which we want to make sure we're expanding access to, because that MS specialty care is so important for the treatment of the disease. So just delving a little bit deeper into this project specifically that really birthed this curriculum and these sessions. Sarah and I lead a project called Improving Access to Diagnostic and Support Resources for Rural Populations Impacted by Multiple Sclerosis in that 4-state region that I mentioned: Maryland, North Carolina, Virginia, and West Virginia. So we can start with a little bit of context setting for this population. So out of all those diseases, why MS? Why did we start here? Well, MS really is a complex, diverse population. When we talk about those demographics that really span that group of neurological diseases, this population you'll see represented in every single one of those demographic elements. MS impacts everybody of all age ranges, all races, genders across that lifespan. What we are seeing is that more and more with increasing diagnoses, this disease is becoming a leading cause of neurologically based disability amongst people aged 35 and under. That has consequences not only for the individual, but for our systems as well. It diminishes our workforce capacity and reduces that individual financial security, often ultimately placing burdens on healthcare systems or public benefit systems. As I mentioned, there is no cure, so this is a disease that is persisting through the lifespan. That means, as many of you know, that patient, that family is going to have evolving needs as their disease evolves as well. And how can we understand and respond to that? And again, it impacts that physical, mental, and emotional well-being. So it really requires this holistic look at that patient's needs. And sometimes, as Tanisha said, addressing other issues that people are experiencing first. An individual living with MS may very much want to follow the advice of their doctor to change their diet and have a diet that is better responsive to their symptoms. But maybe they have trouble accessing that food or accessing those nutritional materials in the area that they live in. So how can we address some of those issues so that they can feel better prepared to do some of the things that they need to do to support their overall health? And similarly, just a quick look at some of that context behind this pairing with rural communities. We know that there is a provider, and particularly a specialty provider shortage, and that is exacerbated in these rural areas. We see increased barriers that these patients are facing, especially when it comes to travel time and transportation, limited mobility capacity, and things that may make traveling far for treatment a challenge. These locally based rural communities may have less social support resources available within the community, and that can make it difficult for folks to access some of that additional help that they need beyond the clinical space. And in rural areas, there are high rates of other factors that may increase the risk of these patients for more severe disability or even death. And so looking at how we can address some of those barriers as well to reduce some of those disparities that we may see across diagnosis and treatment for this population. So Sarah and I have been working with this group specifically for about 2 years now, as we have been developing the 3 branches of activities that make up our project. This has been designed fully in collaboration with people living with MS and caregivers. Sarah holds not only an annual large convening, usually attended by about between 70 to 100 folks living with MS or caregivers, but we have smaller events all throughout the year, whether that's community-based events, conferences, webinars, or even one-on-one conversations and interviews that we host. We are consistently and continually going back to the community to get their feedback on what we're doing and make sure that their voices are really leading the direction of this project. So as we have spoken with them, some of the things that they have really repeated over and over to us and expressed that they want to see really elevated and prioritized in our activities is this lack of providers they feel that are living and practicing in their rural areas that have knowledge of their disease. The general lack of awareness of MS, what it is, its risk factors, early symptoms and treatments, and some of those health-related barriers that we just mentioned. So from the perspective of the community, the way that these issues have specifically impacted their MS journey is delayed diagnoses. They could have gotten a faster diagnosis if some of these issues had been addressed. Delayed or inconsistent treatment. And this isn't always or usually a knock on the provider. We get great feedback about all of the providers that our patients are engaging with that know about their MS and can really provide them with that treatment. But it's some of the barriers that they're facing outside of that clinical structure. So if they are having to travel long distances for treatment, that can interrupt their ability to comply with that treatment schedule. General provider mistrust, as patients are given conflicting or misinformation, that can really reduce their overall trust in the system and over time erode their capacity to keep coming back for more care. Overall reduced quality of life, which can lead to increased or more severe disability. And that can ultimately lead to further issues with managing or having stable employment, especially within this age group where individuals with MS are typically first diagnosed. So here is just a little snapshot of one of our communities, Virginia in particular, where we have engaged with and heard from folks within the MS community. You can see those stickers represent where folks were coming from when they came to our event to engage with us around these topics and share their experiences. And we have a high concentration of folks in this Appalachia, Southwest Virginia, very rural region that have shared these insights with us. So one of the primary ways that we are addressing the issues that have been communicated to us by our community is really looking to strengthen that community-based healthcare worker capacity. This is where you all come in and are champions for the community. Number one, just by showing up today and registering for this session. So thank you so much for that. What we're looking to do here is really just fill those gaps in awareness, provide the needed education and training to achieve these means, and increase access to supportive tools. In addition to this ECHO curriculum, which we've partnered with WVCTSI for, we're also developing a digital network mapping tool that is curated specifically for health and social need resources relevant to the MS and neurologic disease community. This map is really cool because it can work offline. And so that's really important for our rural folks who maybe don't have great broadband access or have really low levels of data that they certainly don't want to spend navigating health resources. So we really love that map and that flexibility there. We're also providing technology assistance to local community-based organizations to make sure that folks engaging with them and seeking services can access the network map and access resources in their community, and standing up navigator centers that ultimately will not only provide access to the network map and navigation services, but in some cases also telehealth sites where these individuals can then better connect with their MS specialists. This approach and the ECHO curriculum that you all are going to engage in over the next 11 months from today has really been inspired by the biopsychosocial model. Just again, coming back to that idea that these folks are really needing help with things beyond their physical health. And oftentimes they feel like they're not able to fully address those physical health needs when they have outstanding needs in the areas of psycho or social support. So sometimes we do need to address those things or just have a better complete understanding of those needs to really make a difference on that physical health side. Just a super quick overview of some of the other approaches that we're taking. We're really looking to integrate some of this medical care back into the community and show that support for those rural folks by meeting them where they are. Sarah has created some great relationships with mobile health units across our 4-state region. We're really looking to target, there's not an MS bus yet, but there are buses that have these great overlaps with demographics that may ultimately be at risk for or be exhibiting early signs of MS. And it's those folks that we're really trying to reach. We not only want to help address needs for the existing MS community, but those people that might be diagnosed in the future or going through the process of diagnosis now, we really want to be able to grab them and pull them in earlier and make sure that we are reaching people even outside of some of these traditional health pathways. And so one way that we're able to do that is, for example, by partnering with buses that are focused on reaching women. Women are 3 times more likely than men to be diagnosed with multiple sclerosis. And so by reaching a broader population of women and providing awareness and education about MS, what it is, its risk factors, and its early signs, we can hopefully catch those few people out there who do have that intersection and get them into that treatment earlier. Similarly, we're targeting buses that provide vision services. We're targeting lung cancer buses, anything that might be a common comorbidity or early symptom. We want to reach those populations and educate them so that they can recognize those signs early and advocate for themselves. And then before we get into hearing from you all, I do just want to make sure that we are always bringing it back to our most important focus, which is our community. So we have here a picture of 2 of our biggest champions in the community with the Multiple Sclerosis Alliance of Virginia. We really hope that the voices of patients and caregivers resonate throughout all of these sessions, and that you're not only seeing the needs of the community being expressed, but seeing reflected back those needs that you know exist in your communities, and some of those challenges that we know that you're facing with the patients that you're providing care and service and support to every day. So I think that's what we're most excited about, is being able to share these real experiences and really address some of those questions that you all have to help better support and empower your communities in care. So those are the contact information for Sarah and I. I know everybody has Jay's information, and I think through the ECHO curriculum, he'll always be your primary point of contact, but he can share things with us, or please feel free to reach out to Sarah and I directly if you ever have any questions, ideas, or comments for us about this curriculum in particular, or about our project overall, and ways that you might see to improve our services and impact for these communities. So before I turn it back over to Jay, is there anyone on the call that has any questions, comments, or wants to share a little bit about why they joined and what their goals are, or what you're hoping to learn from these sessions?
Yes, please feel free to unmute or use the chat. Go ahead, Melanie, I see you unmute.
Yeah, I was just gonna say, from my standpoint, it's always nice to know what the questions in the community are, because sometimes, it's hard sometimes to coordinate care for every patient, depending on where they live and who else they're seeing. So it's nice for us to know from the other end what concerns there are and how we can help.
All right, well, I'll go next. So one of the things that I mentioned earlier is that so the organization focuses on, and I don't know if I said that we're based in Baltimore. I don't know if I said that that's where I was located. So, but as we start to think about providing social support and navigation, we have to perform health risk assessments. And so how do we, using tools, like when we look at some of the tools that are available, I don't think they really touch on this type of topic, right? So how do you incorporate, or how do you, because we're not really, I'm not a licensed practitioner, right? So I can only ask questions that might help to provide enough information for someone that could perform that type of medical assessment, right? But what questions do we incorporate into assessments that we look to create when we start to move into more expanded or move into navigation? So I'm hoping that what I learned from this, so the goals would be understanding the condition, understanding what the community is like that you've been engaging, right? And then definitely the tool, right? It's nice to know that there is a tool that has resources that is available offline. Okay, I understand it's mostly for rural communities. For West Virginia, that's the area the tool covers right now. Is that correct?
So the tool actually covers the 4-state region,
Okay.
Tanisha, of Maryland,
All right.
Virginia, North Carolina, and West Virginia.
Okay, right. And that's key, being able to access something that's offline. So just how to use that tool, right? As I think about those types of resources that are available, it's, well, how do I also provide that information to someone that I am talking to, where they are, right? And working through what that solution looks like. Not that I'm going to get that from this discussion, but definitely understanding how to use the tool and how to incorporate that into what we do. And I'm going to stop there because I feel like I'm rambling, because I just have just a flurry of thoughts. So,
Yeah.
but those would be my top, right? So understanding the tool, understanding more about the community and it's the challenges of the community and, what types of questions to ask in order to better identify population.
Thank you so much for sharing that, Tanisha. It's really helpful to know, specifically what you're hoping to get out of things so we can respond to that. I think you will get a lot of what you're looking for out of the sessions that Jay and his team have designed and the information that will be shared through some of the speakers that are lined up. But honestly, I would also love to just connect offline and talk a little bit more about your model and your structure and how you're approaching some of these implementations so that we can identify sort of the best ways for you to move forward, especially around some of those questions that you have regarding the billing of the health risk assessments and things of that nature. So yeah, I would love to connect offline and really just learn more from you about what you're doing and be able to respond that way. So thank you.
Okay, thank you.
Go ahead, Eric. You have your hand up.
Yeah. So Lauren, I'm not as familiar with Virginia counties as I am with the West Virginia ones, although that still leaves something to be desired. Can you go back to that slide of the counties and where the patients were from? Yeah. So it looks like a lot of people are from, is that Roanoke, Franklin?
Yeah, around that area. The event was actually held in Roanoke, so you can
Okay.
imagine that it concentrates there and then kind of spans out. We did have some participants from Maryland, North Carolina, even as far as South Carolina, West Virginia, but it was definitely a little bit more concentrated in that Franklin County, Roanoke County area because of the location of the event.
Gotcha. And that's pretty, I mean, it's fairly populated. I mean, and they have a lot of medical resources there and things. I mean, the hospital, I think it's the one that's associated with Virginia Tech is there. I might be making that up. I'm not sure.
Yeah, in the actual Roanoke area, there are definitely resources, but the patients that are living in like Floyd County, for example, down here, that's a pretty far away for them to travel, especially when they're dealing with some of their MS symptoms. And, we know in Floyd County, for example, they don't have access to an X-ray in that county. Those patients have to go, a county over to even get an X-ray. So when we're talking about something like an MRI or repeated MRIs or treatment, they are definitely having to travel. So even when we think about proximity on a map, 2 counties over doesn't look that significant. But when you bring in the logistics of caregiver and travel and expense and time and energy, it is a very daunting, repeated experience.
Gotcha. Yeah, we kind of always, from our end, think about patients that are really far away from Morgantown, but I mean, even 20 minutes, you're in the middle of nowhere. So good reminder that even one county away from a pretty decent hub, and we still have a whole bunch of unmet needs.
Yeah, and I've driven through West Virginia quite a lot. And from experience, if you're not familiar with an area, a 20-minute drive can quickly turn into an hour when your GPS goes out and you're just kind of like making right and left turns, hoping to make it back to civilization at some point. Sarah remembers playing this game with me. So, but again, as people are traveling a little bit further out from their home base, there's always those additional challenges that are going to come up for them.
Any other questions or comments? This has been great.
I was just going to add to, this event provides the opportunity to not only learn more about MS and the population and treatment, but as you consider inviting folks to join as well, it really provides an opportunity to connect and to the bigger resources, the larger institutions, the neurologists that are available. So, we really want to encourage that frontline primary care providers, nurses, please extend invitations, welcome people to this, because it does provide both the educational opportunity and the opportunity to connect resources.
Yeah, and I think that's, one of the most important things for us to end on before we hand it back over to Jay and the team is we are not providing these sessions with the expectation that you all are going to become MS experts and suddenly take over treatment and all of the care for these patients. It's really more about that partnership, that collaboration, that awareness and understanding, so that when you get one of these patients coming to you, which you will, even if you don't know it, you'll just feel more confident in knowing what to do and how to help them and who to refer them to and how to have that collaboration with the specialist, so that, as Melanie said, you really can coordinate all of those needs and get those better outcomes. So we don't want the MS specialists to go away. They're so important. We don't want to put more burden on the frontline workers. We really just want to make it easier for everyone to have some shared knowledge and work together.
Thanks, Lauren and Sarah. Again, that was a great presentation. We really appreciate the information. Just as a reminder, you'll get copies of the slides, and we are recording the session, so you'll get a link to watch it again. So don't worry if you missed anything or want to go back and check things out. You'll have the opportunity to do that. Right now, we're going to move on and talk a little bit more about the echo sessions moving forward. So a little bit more into detail, I'm going to share some brief slides. We'll go through, but if you have any questions while we're going through the slides, please pop them in the chat, raise your hand, or just unmute. Happy to answer them. So let me just go ahead and pull these up real quick. All right, now most of you are familiar with Echo, I'm sure, or have heard of Echo or this type of model where it's basically a hub and spoke approach, where we have a group of experts on one end, so an MS or neurological diseases on one end, and then primary care, doctors, nurses, but it can be also anybody, social workers, administrators, anybody, community members just at large can be those learners on the other end of an Echo project. And it's really to do what Lauren and everybody was talking about, Melanie, about sharing resources, sharing knowledge, getting the most information out. And we do that through two main items within the session that we'll get into here. Switch this. There we go. But this just gives you a representation of what the Echo model versus telemedicine, what people mostly know about telemedicine. That point-to-point, this is more of a group to hopefully a bunch of learners that can kind of disseminate the knowledge more broadly, and with the goal to keep, patients in the primary care setting longer if that's their goals. Also to help with the referrals to those specialists so that they're seeing them at the appropriate times and can make those travel plans, and all that goes into, getting that access to care. So just a brief recap about the project. So no cost to join the session. So be sure if you are talking to your colleagues, there is no cost to coming and joining the sessions. They're going to be an hour long. They're going to be monthly sessions. We are going to record them and put them in our YouTube page. They'll also be uploaded into the iEcho system, which we'll go over here in a minute. And then we are going to offer a CME for the sessions for all that attend. It's a general medical education credits. If there is something that's more specific that you need for your CE needs, please let us know. We can always adapt and be flexible and add on things as we go. But we always start out with the one general hour for most. And this just shows you some of the other offerings we have, but really focusing obviously on the MS and neurodegenerative diseases project. So this is the Echo team. So you could be hearing from any one of us, primarily me for this one, but there's also Mitra Salmasi and Elizabeth Minnick, who are our manager and coordinator for Echo. They can help you with anything that spans the Echo universe per se, technical issues, getting signed up, access to YouTube videos, anything like that. Please let any one of us know, and we'll get you set up. We did have a few folks that had issues with getting on the session. It was kind of blocking them. So we're going to be following up with them. So if you ever have anything kind of happen with your access, please let us know. Okay, so new Eye Echo. This is new for everybody. Just launched here in the beginning of the year. And this is basically a new platform for the Echo movement. They're using it to basically be a one-stop shop for Echo. You're going to be, joining the sessions through there. You'll get reminder emails from the system. You'll also be able to have access to all the content from the session. So PowerPoint presentations, recordings, anything like that will be uploaded into the system and available through the project. Please, remember that it's a one-time sign up. So once you have your account, you're in. Don't be making multiple accounts. You don't have to. You can just log in. Also, the reminder email has a Zoom link in it. And so you can just click that as well when the sessions come up. And I just wanted to show you this landing page. So if you're in the project, if you joined, you can get access to the content in two areas. One is through the content tab here. The other is when you log into your account and you go to the project page, it shows the schedule. And in the schedule, all the content that is specific for that date is uploaded here as well. So it's in two different places. Really pick your best way you want to do it, but that's where it'll live. And again, that'll include anything and everything that's included in the session. The one thing that it won't have in there is any of the case presentations. We don't upload those to the system. Those are just for the people that present it. So you won't find that information in here. Any questions on new Eye Echo? Did anybody have any issues getting on? I know you guys are on, obviously, but did we get the email reminders? Anything like that? If there's any issues or anything you had come up, please put that in the chat and I'll take a look at it after we're done presenting here. But it's new to everybody, so we're learning as we go. So we appreciate any feedback you can give us. Okay, so the sessions for Echo are broken into two parts. You have your didactic part and your case-based learning part. So the didactic is really going to be focused on this curriculum here. Now, the caveat with the curriculum is that it's flexible. So if we talk about MS screening in February here and something comes out of that talk where you need to, we want to learn more or try to nail down on a specific part, we can absolutely get that included into the curriculum, switch things around and make sure, the curriculum fits your needs. It's really for the learners. So we want to make sure that it's worthwhile to take that hour out of your day to come to the sessions and get the information you want. So please let us know. Don't be shy about that. If there's something you need to learn, please let us know. But this is the general outline that we're going to follow. And so it's going to be the basics. It's not going to get into too much detail. The didactics are only 20 to 25 minutes. So it's going to be hopefully easy for you to digest, have further questions, feel a little bit more comfortable. Like Lauren was saying, just, it's not to make you an expert. It's just to really help you get a better understanding and know what's available to you as far as resources or anything like that. The second part is the case part. And this is really where we're going to lean on the participants for the sessions. And everybody kind of gets a little bit nervous when we say, oh, case presentations, but case is a loose term, okay? A case can be anything. It can be about a de-identified patient that you see in your clinic, or it could be a question you have around resources, policy question, a practice question. Can be about a group of patients that share the same characteristics and you want to get some information on them. This is, we tried to make it as easy as possible for the participants to fill out the case, present the case, and really feel comfortable getting the information, the feedback back from the group. So the presentation part should only take 5 minutes. We don't need every information, all the information on the specific patient if it is. It should just be enough to get the discussion going. And so what I'm going to do here is actually stop sharing this, and I'm going to show you the case form itself real quick, just to give you an idea. So it's an electronic case form. You can do it on any device, on any platform. And the required questions are the first three, which is your name, where you're from, and then what date you want to present. And the dates that are loaded here are the session dates for the project. So if you want to submit a case now and not present it till May, go for it. It gives you that flexibility to submit cases whenever you want. You can do it the day before, anything like that, but it just gives you that flexibility to submit it. It comes into, logs into our system here. We'll make note, you'll get a copy of it, and we're all good to go. But it's really broken down into these questions here, 4 through 10. And again, these are not all required questions. You fill in what you can. They're text boxes, so you can copy and paste from your EMR. Obviously, we don't want any PHI in there. That's in the instructions, so please be mindful of that if you're doing any copying and pasting. But it's just really give us a little bit of background on the situation, what's been done, what's your kind of initial assessment, or maybe there hasn't been an assessment and you need there to be an assessment. And then if there's any data, this really comes back to if you have labs or medications and things like that you want to include that have been done before. And then what are your big questions? What should I do next? What, should I run this next test, prescribe this medication, etc. You do have an option to upload a file. It can be a picture, an x-ray, something like that. The main thing is that we can't have any identified information on it. So please scrub their name if you do upload something. The good thing is, I will tell you, is that we do a second check when you submit the case. So when you submit it, we'll see it. We'll go through all the information. And if there is any PHI in it, we will remove it and send you an updated version and let you know that there was PHI in it. And that's why we had to take it out. And then there's obviously any additional comments that you want to provide. And it can be on anything. It can be on the case. It can be on the case form itself. If something is missing or anything like that, please drop that in there for us. But that really is the nuts and bolts of an echo session. It's those two main parts, the didactic and the case-based learning. And we want to make sure we have each of those at the sessions. So, we will bug you to provide some cases or questions if we don't get any. Just keep in mind that it's really supposed to be not this painstaking thing. It's supposed to be very easy for you, very informal. This is a discussion amongst the group, and to give you the information you need. Let me see. Are there any questions on any of that so far? Just want to make sure. I see there's some stuff in the chat. Let me make sure. Okay, that's about the iEcho stuff. That's good. Okay. Okay, so Eric, so you got the email with the calendar invite, which we will be sending to everybody. That is the one thing about the new iEcho system that we can't do that we've done in the past, is put the Zoom link in the calendar invite. And that is because each one of us has a unique Zoom link, and the reminder email that you get 30 minutes before, or logging into your iEcho account and joining through the project page, is the only two ways that you can join the sessions now. And that's a security thing that the Echo Institute has done. It is a little bit cumbersome. I totally agree. I mean, it's usually pretty easy. You open up your Outlook, hit the link, and you're good to go. But unfortunately, we can't do that. So we will provide the Outlook calendar invite, but we will just make a note to log into your iEcho or to please use the link in the reminder email. We'll put that in the body, but unfortunately, we can't do that. Hopefully, if they integrate it a little bit better, they are making improvements as we go. Maybe we get to that point, but as of right now, we can't. Sarah, I see you had some issues with the password box. Okay, I'm going to send that to them and let them know there was some glitches on that. We always want to provide feedback to them, so this is great. Keep it coming. And Lauren, I'm glad that you got the reminder emails in the navigation system. Yeah, so that once you get through the email and into Zoom, hopefully Zoom will act the way everybody knows Zoom to act. But again, anything that would happen, any slight little thing, even little hiccup, please let us know because we can report that to their IT team. We can help you navigate any issues that might happen. So we appreciate the feedback. Thanks for putting that in the chat, everybody. But we have 3 minutes left. Is there any questions or anything like that? We're excited for everybody that has joined. We know we'll have a couple more people on the next time once we get their IT stuff squared away. But anything in the meantime? Okay. Our next session is going to be February 7th. We're going to be talking about MS screening. So we're going to get into the basics of that. You'll get some reminder emails and some encouragement to submit some cases for those. So be on the lookout from that. They will come, the reminder emails and things like that will come from iEcho. That's who the sender will be, but it'll be me sending you the email. But so you might have to add that to your safe sender list if it goes to your spam. So we'll be mindful of that moving forward. But in the meantime, we wish everybody a happy new year. We look forward to seeing you in the sessions moving forward. And please don't hesitate to reach out with any questions or anything like that. We're here to help. All right. Thanks, everybody. Have a good rest of the week. See you next month.
All right. Thank you.
Thank you.
Bye.